Thank you, Chairperson, for that generous introduction. I'd like to, first of all, congratulate the organizers, particularly Dr. Sedicott, for organizing this massive and very informative and very high standard meeting, of which I'm very proud to be part of. So, yeah, I think I can increase the volume a little bit. So, I was asked to talk on the subject of importance of avoiding clinical inertia in treating diabetes, and I'll try to keep this talk as simple and clinical as possible. So this will be the structure of my presentation. I'll first define what is clinical inertia and talk about that, and then we will talk a little bit about how early should insulin be initiated in the treatment of type 2 diabetes. So what is clinical inertia? The term clinical inertia is defined as a lack of treatment intensification in a patient not at evidence-based goals for care. In other words, the failure of the healthcare providers to initiate or intensive therapy when indicated. So we all know that we have guidelines to meet, we have got targets, and we also know that these guidelines are very much individualized. So there's no one size fits all. So it's not A1C7 for everyone. We are aware of that. But whatever targets that you set for the patient sitting in front of you, if you think that that patient has not achieved the target, and we still don't react to that, and we let it pass, then that's called as clinical inertia. Here is a study published in Diabetes Care by Shah et al., where they look at both specialists who treat diabetes as well as primary care physicians, and shown here are 4 indications. Any drug intensification, when does it occur? How many people do they use any drug intensification at all? Then adding a new oral agent or increasing the dose of an existing drug. And last is adding insulin. So when do you think you should add insulin? And given here the percentage of patients who went through that drug intensification, and you can see that if you look at insulin at least, it's very few people at the time when they felt that that intensification should have taken place, less than 10% of doctors actually did it. So for some reason or the other, we keep postponing it. Again, when you have to increase a dose, again we hesitate. Should we do it? Shouldn't we do it? So there is this little bit of, and then there is of course some differences between the specialist care, at least with relation to insulin. At least the specialists are doing better, the primary care physicians are not doing so well. But if you look at the oral drugs, there's really not even much of difference between the specialists and the primary care physicians. We addressed this in a study published recently, where we looked at the study called as the Time to Do More study, where we address clinical inertia and the management of type 2 diabetes. This is a multi-center study, several countries involved in this, and we looked at the pattern of care in various diabetes centers to see whether clinical inertia actually exists, and then to try to kind of make some policies or statements or guidelines on how to overcome this inertia. Everybody talks about the inertia, but no concrete steps are taken to address it. So what we concluded in this paper is that the principal findings of the survey suggest that impairment in communication is the heart of clinical inertia. In fact, I'm not going to dwell too much on this paper. I know 3 times this topic is being presented in this meeting. But suffice to say that what the physicians thought they had conveyed to the patient was very different from what the patients thought that their HCPs had conveyed to them. There seemed to be some kind of a mismatch here. And essentially, it was this lack of communication which was resulting in the clinical inertia. And therefore, we laid down 4 key principles which we believe are achievable in all environments and can help to improve the lives of people with diabetes. And these are the 4 key principles which are enunciated in this paper. The key principle 1 is that the health outcomes of people with diabetes are a function of the communication between the healthcare providers and people with diabetes acting as a team. So the more we work as a team, the educator, the physician, the patient, and all people concerned, and the communication channels are clear and open, then initial clinical inertia is unlikely to occur. For example, telling somebody what is the need for insulin and what is the need for attaining tight control and what might happen if you don't will certainly help to reduce this inertia. The key principle, too, is that it is the duty of that team to establish realistic shared goals and a contract in order to achieve these objectives. Somebody is coming to your clinic, and every time for the last 5 years, this patient has had an A1C of 12 or above. 12, 13, 13.5, 12.4, 12. If you tell this patient, I want 6.5, it is a little realistic in that particular patient. It's extremely difficult. So why not we start with 9? I know 9 is very poor control, but somebody's got 12.5, if you bring it to 9%, it's a good start. It's like telling somebody who's overweight by 50 kilos, I want you to lose 50 kilos in the next 3 months or 6 months. That's not going to happen. If you tell the patient, can you lose 5 kilograms, then somebody is going to listen to you. So that's to set realistic shared goals. The third key principle is that individualizing care needs to be personalized to all aspects of the need of the person with diabetes. So if you have a very high risk, and this of course is beautifully enunciated and articulated in the ADA EASD guidelines, where they talk about the need for stringent control and the less stringent control. So the person sitting in front of you is not somebody taken out from a textbook, but it is an individual with a character. And that person brings with that person a lot of baggage. They may have hypertension, they may have heart disease, they may have had a stroke, they may be old, they may not have support, family support, they may have socioeconomic problems. I think all these influence, rather than simply chasing blind glycemic blood pressure and lipid targets, although having said that, these targets are extremely important and we should still chase them. The key principle 4 is that purchasers and providers should incentivize good management in early disease in order to optimize quality of life for those with diabetes. And this incentivization may be as simple as a pat on the back. It may be just one good word saying that, hey, you have achieved this. Great. Now let's aim for this. You've got 8.5%. You know what? Next time we're trying to aim for 8%. Can we do it together? And that one simple incentivization may be all that is needed, believe me, to get targets. You don't need to use costlier and costlier drugs and more drugs. Even as simple as that might work. Let me put this to you in a hypothetical context and then try to tell you some real-world data. We talk about A1C of 7%, but we also know that this 7%, even if you achieve it, is not something which you can keep the patient on forever, because there is a natural history of diabetes, there is a natural deterioration in beta cell function, and with that, the A1C will begin to rise. And when it rises, you carry with you, or the patient carries with him or her, the glycemic burden, which is shown in red. So one of the key points, if you want to prevent clinical inertia, is to get that patient sitting in front of you to come back again and again to you, to your clinic, because you and that patient then have additional opportunities to try to cut down the clinical inertia and to get the sugars under control. So if, for example, shown here at the bottom are months. So if you're going to wait for that many months, then that many months of glycemic burden this patient will accumulate. But what if you brought the patient back earlier? Then now you have a chance again to bring the A1Cs down, and therefore this is still unavoidable because they came back only there, but that at least could have been avoided. What if they came back earlier or earlier or earlier? So if they did that, if they kept coming back to you in time, then all this could have been avoided, and therefore that imprinting which occurs on the cells, which actually leads to retinopathy, nephropathy, and neuropathy, could have been prevented, and only this much is unavoidable because that's the point at which they came back. So the moral of the story is, if you want to prevent clinical inertia, see that your patients come back to you if they are not under good control, and indeed if they are in good control, because that's the way you're going to keep it under good control. If you don't do that, what happens? Then this results in a huge burden of complications. We have heard about the diabetes epidemic, we have heard about the numbers and so on, but what you should also keep in mind that is that when you have diabetes of long duration and you have large numbers of people, as in India, you also have a huge burden of complications. And these are urban figures and rural figures. All are population-based figures from the Chennai Urban Rural Epidemiological Study, showing you that there are millions of people in India who have one or more of complications. Some of them have more than one of these complications. If you just take kidney disease as an example, almost 17 million people in India with at least some form of kidney disease, at least microalbuminuria. And the chances are that at least a third of them, even if you use conservative estimates, will go on to develop end-stage renal disease. And this is not something that we can handle. Another paper we looked at a simple question. We just asked a simple question. I showed you the hypothetical red graph showing you the glycemic burden. How does this translate in real life? So going through our large electronic records, we looked at a 9-year follow-up study of patients who come to our center and divided them into those who come regularly for follow-up and those who come irregularly for follow-up, defined as at least 2 to 3 visits a year minimum and 1 visit or less than a year for follow-up. And we looked at the complications rate over the 9-year period. We are talking about incident complications, which means those who did not have retinopathy, nephropathy, or neuropathy, or peripheral vascular disease or coronary artery disease, developing this during the 9-year period. We also calculated what's called as a glycemic burden, and this was calculated using a formula using multiple HbA1c levels. And this is shown here. If you look at the 9-year follow-up period, these are the A1Cs in those who came for regular follow-up. And the next one shows you those who came for irregular follow-up. So you can see that those who did not come regularly for follow-up trend to track A1C levels, which are always uncontrolled. Here we are trying to get them under control, and there are chances that this person can be brought down if they come back for regular control. From this, we calculated what's called as the glycemic burden. And this glycemic burden is shown here, and that's the glycemic burden in those who come regularly for follow-up, and that's the glycemic burden in those who do not come regularly for follow-up for 9 years. Remember, at the start, none of them had any complications, and over this 9-year period, what is the incidence of complications in this cohort? And that's shown here. You can see that the unadjusted as well as the adjusted, of adjusting for all the confounders, retinopathy almost doubles in those who do not come regularly for follow-up. Nephropathy also doubles. These two reach statistical significance. Neuropathy did not reach statistical significance because it's measured by a crude method, and also some neuropathy occurs with age. With peripheral vascular disease, coronary artery disease, we did not find any statistical significance. But as of point to note is that retinopathy and nephropathy, the two specific complications of diabetes in a real-world situation, in a clinic, just by the fact that the patients come back regularly for follow-up, we were able to reduce the glycemic burden and thereby prevent the incidence of retinopathy and nephropathy. Is this possible over a long-term period? This was published in Diabetes Care 2 years ago, where I think this is still the only paper in the literature on type 2 diabetes, where we report from this long cohort of people, a set of 238 patients with type 2 diabetes, adults with type 2 diabetes, who have survived a minimum of 40 years without complications, and many with 50 or more years of type 2 diabetes. And what's the message at the end of the paper? Because we also had a group of people who did not survive, and we compared them in this paper. Conclusion is plain vanilla. There's nothing there at all. Long-term survivors with type 2 diabetes had better glycemic control, blood pressure control, and more favorable lipid control. So what Gray et al. Showed in the New England Journal paper in the STENO2 study on 80 people is actually translatable into the real world, into thousands of people, if we as clinicians follow the rules and prevent clinical inertia. So let me now switch tracks and talk about how early should insulin be started. This is the classical paradigm, okay? Our patients keep telling us, please don't put me on insulin, doctor. I hate it. Please don't put me. And in a busy clinic, when you have 30 more patients to go, you say, okay, let this one pass. It saves me half an hour of my time, okay? And so what happens is that finally when patients enter the stage of complications and you tell them that you've got retinopathy and nephropathy, then they'll ask you, how many times should I take that insulin that you asked me to take? The problem is it's just a bit too late because the complications have already set in. When all else fails, when all your 8 classes of oral drugs fail, common sense tells you that at least now think of insulin. But I would submit to you that a considerable amount of glycemic burden has already occurred. I'm now going to throw across a challenge to you that is there a place in treatment at the time of diagnosis of diabetes where you give insulin for a short period of time to try to change the natural history? In other words, is there any benefit at all in initiating intensive insulin treatment at the time of type 2 diabetes, and can beta cell preserved by early insulin treatment? The hypothesis is this, that if you don't do anything in the observed natural history, there is a slow but inexorable decline in pancreatic beta cell function. And can you slow that down, and can this be done by early insulinization? The best study is by Wang et al. The Chinese are always beating us in doing great studies, and this is one example of that, where about 100 patients in each group of newly diagnosed type 2 patients were given either a subcutaneous insulin infusion for about a month, or multiple daily doses for about a month, or just plain vanilla oral agents, the glycoside and metformin treatment, which we normally give. And the point here is that while at the end of the 4-week period, the insulin levels were not significant between the 3 groups, at the end of a year, the group treated with either the subcutaneous insulin infusion or the multiple daily doses of insulin did not see a rapid decline in beta cell function as compared to the group treated with glycoside and metformin, where there's almost a 60% drop in the pancreatic beta cell insulin reserve. Based on this, if you read the Chinese guidelines now, straight away the guidelines said, the Chinese Diabetes Association and the Chinese guidelines straight away say that if you have uncontrolled diabetes where A1C is more than 8.5 and type 2 diabetes, give insulin for 1 month. They believed their study and they said go ahead. Of course, we have the GRADE study and the RISE study now going on in the US, which will give us much larger studies, which will give us the ultimate answers. They might give us the more mechanistic views on this. We'll wait for that. But I'll show you a few of my 2 or 3 of my patients whom we have treated and then end with this. This is a 53-year-old male. To make it clinical for many of the younger people in the audience, the postgraduate students and so on, this is a 53-year-old male, 8 months duration of diabetes, central obesity, was on glycoside, uncontrolled diabetes, blood sugars were high, A1C was 11.4. Given that each introduction of an agent might reduce the A1C by about 1%, we went aggressive because already we lost 8 months. We could have lost much longer because we could have had long period of uncontrolled diabetes. We actually added sitagliptin, glycoside, metformin, and gave insulin. At the end of 4 weeks, insulin was stopped and the oral agents were continued. And this is what happened. Even after doing all this, the A1C dropped from 11.4 to 7.1, which we thought was quite good for a person who had those kind of values. But more impressive was, this is one of the first cases we studied, where we showed that there was a dramatic increase in both the fasting C-peptide as well as the stimulated C-peptide. So when you had these kind of low C-peptide values, one might be under the false notion that the beta cells are completely gone and that they cannot be revived. Here is an instance where by aggressively treating this patient, you're actually able to improve the beta cell function quite dramatically. And therefore, this is the concept of the functional recovery of the beta cells, or recovery from beta cell stunning. So the cells are not dead, they're only stunned. Here is another case of 2 brothers, developed diabetes almost at the same time. Stress, somebody mentioned stress in the earlier presentation. So this was stress, their father died, and 2 brothers developed diabetes almost at the same time. So one of the brothers went to one of our branches where we treated them aggressively with insulin, and you can see this is the reduction in A1C. Now somebody who had 11% at onset, getting the A1Cs down to 5.4 and 5.5 is not something which I had seen 10 or 15 years ago in my practice. If they come down to near 7, we would be extremely happy. But this is possible early in the natural history of diabetes, just after onset. This is the only time probably they'll get these kind of A1C levels. Later on, it will be difficult to get 6, to get 6.5, and indeed even to get 7, it can be more difficult. And again, a prompt recovery in the beta cell function. His brother, on the other hand, was treated more conservatively, and you can see that the A1C, of course, there's a 5% reduction in A1C from 12.8 to 7.9, but that's the kind of best he's going to get in that situation. And these are the patients who after 2 years, 3 years, even to get 8%, 9% is going to be very difficult unless we treat them very aggressively at this point. And it, not surprisingly, only a very modest recovery in beta cell function, unlike his brother. Studies from Dallas have shown that this beta cell function preservation can be maintained for as long as 3.5 years. And I'm sure there are studies coming up which are much longer. So this study, for example, tells you that beta cell function can be preserved for at least 3.5 years with early and aggressive treatment, provided there's a 3-month insulin-based treatment period given initially. So if you give insulin for 3 months, for 3.5 years after that, after the insulin is withdrawn, the beta cell function is preserved. And a systematic review in the Lancet also shows that short-term intensive insulin therapy can improve the underlying pathophysiology in early type 2 diabetes and thus provide a treatment strategy for modifying the natural history of type 2 diabetes. So if you start aggressive early when you can, then the benefits of that seem to last much longer, and that's what metabolic memory is all about, and that's what the legacy effect is all about. And this is because reversal of glucotoxicity and lipotoxicity occurs. We know that there is reactive oxygen species and oxidative stress, and this seems to be improved rapidly with restitution of euglycemia. And we also know that the mechanisms are beginning to be understood. We know the role of FOXO1, and we know that FOXO1 is responsible for a healthy beta cell. When FOXO1 goes away, like you have metabolic stress, uncontrolled diabetes, FOXO1 goes away, and what the beta cell does, it doesn't die immediately. It de-differentiates itself into an alpha cell or a delta cell. It's actually going to kind of hiding and trying to hide there, hoping that the enemy would go away, the enemy in this case being metabolic stress. And then it can come back. But if you don't do that, then the cell is lost, as shown in this cartoon here, where you can see there's a healthy beta cell, it's getting exhausted, there is metabolic stress, this is the stage of functional damage. If you relieve that stress by early and aggressive insulin, just even given for a month, then what happens is this beta cell, which is de-differentiated into other islet cells like alpha and delta, can go back to become the beta cell again. But if you don't do that, then there's more metabolic stress, decreased beta cell mass and apoptosis, death of the beta cells, permanent insulin damage. And at that stage, if you go and try insulin as we normally do, as I showed you in that schema, very late, then obviously you don't get very good results. So I'd like to conclude, ladies and gentlemen, by saying that clinical inertia should be avoided when treating diabetes, and communication with patients is the key to prevent clinical inertia. Number two, it's important to keep the A1C levels continuously below 7%, again, with the caveat that there are many patients who cannot achieve that. But in those whom you can, try to get the best A1C that is possible in that patient at that given point of time, because things change in the clinical history as you go along. So right from the onset of diabetes, if you do that, then you can prevent microvascular complications. We have seen this in randomized clinical trials, and I showed it to you even in a real-life setting in a large clinic. If macrovascular complications are to be prevented, then in addition to glycemic control, blood pressure control and lipid control should also be done. And if these measures are followed, long-term survival of patients with type 2 diabetes is possible, and they can live their full lifespan despite the disorder. Thank you.